Welcome, everyone, to part 2 of our series, Understanding Hospice and Palliative Care series. Tonight's presentation is titled Serious Illness Support, brought to you by Maureen Burns, Senior Community Education Associate and Research Liaison at the HAP Foundation. This is as I said, this is the second part of a 4-part series. Next week's presentation will be Coping with Grief, and it will be in person at the Evanston Public Library in the Falcon Room, room 303 on the 3rd floor. And the 4th week of March, March 27th, from 6 to 7, our last series will be Navigating Career Stress, and that will be in our community room on the 1st floor at the Evanston Public Library. And I will now hand it over to Maureen.
Thank you, Irene. Thanks everyone for being here. I will go ahead and share my screen and we'll get started. Okay, so hopefully looks like we have some returning folks that were with us for the first session and maybe some new people as well. Thanks for taking time out of your busy schedule to be here. So this presentation is Support when living with a serious illness. As mentioned, my name is Maureen. I use she, her pronouns or ella in Spanish, and I'm with the HAP Foundation. So once again, I just thank you for taking the time. Nobody usually wakes up in the morning and says, ooh, I want to learn about serious illness support, or I want to discuss end of life care. It can be scary. And because of that fact, people often miss out or they don't know what type of care is available until they're in a crisis and maybe they need it. So the idea behind this is to give people an idea of what's out there, whether or not they need it now so that they can be prepared. I'm not going to go too deep into this because I think a lot of you met me in session 1, but I'm a community health worker. I'm based in Rogers Park, and I work all over Chicago and the suburbs, talking about topics that pertain to serious illness or end of life care. And I do this for the HAP Foundation, which is a nonprofit. And we have our community education. And then we also do clinical education, advocacy, research, and workforce development. All of it kind of aimed at improving serious illness support and serious illness care, which is what we will be talking about tonight. So during this presentation, we're going to talk about some of the supports that are out there if someone is diagnosed with a serious illness or with a terminal illness. Obviously, when this happens, it can be heartbreaking, scary, overwhelming, and having these type of diagnoses can prompt a lot of uncertainty, not only for the person experiencing it, but for their loved ones. So the goal today is to help everyone know what care and support is available. So we're going to talk about that, specifically palliative care and hospice care, how they're similar, how they're different. And we're going to talk about the process for accessing those types of care, who is eligible, who pays for it, and what that care looks like, what the benefits are. As I said previously, a community health worker is someone who acts as a bridge between community members like yourself and healthcare providers or social service entities. And so at the HAP Foundation, I do this community education, and I also do resource navigation, helping to link people to care. So I will share my email address if anyone ever needs help with questions, with finding a provider. I'm happy to assist you. So I want to start with this figure, these statistics, which comes from the National Hospice and Palliative Care Organization. So before we even define hospice care, It's important to note that hospice care is still a young movement, both in the US and worldwide. And many people are not using hospice, right? Across all these racial groups, we see that more people could be using this type of care. So this figure shows people who had Medicare, who died, and it shows the percentage of those people who used hospice before their death. So as we can see, white Americans tend to use hospice at the highest rate, followed by Asians, followed by African Americans, Indigenous peoples, and Hispanics. So I think this is important because one, it shows that education is needed across all racial groups. People need to understand what hospice is and how it helps. Hospice is a choice. We never want to force someone into using hospice if they don't want to, but we do believe that people need to be well educated so they can make informed decisions. Also, this slide, shows that there are significant racial disparities on who is using hospice. And so there are many reasons for these disparities. There's many reasons, why white Americans use hospice more than Black Americans. And in order to address these disparities, it's important to have opportunities like this where people can get education that's easy to understand and that's respectful of their lived experience. And part of why these disparities exist is racism, and mistrust, which is a legacy of historical racism and current discrimination. So at the HAVE Foundation, that's a big focus for us, is addressing not only the utilization disparities by race, but also kind of what is behind them, getting at what is behind them. We recently did a research study with Black Chicagoans, where we did focus groups to kind of get their perspectives on their experiences caring for loved ones who were dying. So that was a really interesting study that's going to inform our work as we seek to make sure that we are offering education that gives everyone equal opportunity to access hospice and palliative care if they so choose. Another part of this is also what we call the social determinants of health. So this is really the idea that whether we're talking about our mental health, we're talking about chronic diseases, serious illness, hospice care, we are more than just people who get diseases, right? And there's more factors that influence our health besides just genetics. So it's our environment, right? Our access to resources, all these things, all these factors of where we live, where we grow up, where we work, they all impact our health. Racism is an example of that, but also sexism, access to healthy food, all of these things impact our overall health. And they can also impact our experience of quality end-of-life care. So as I said, we're going to be discussing some supportive services for serious illness. So I think it's important to start by defining what I mean when I say serious illness, because I am using the clinical definition. You may hear someone else, say, oh, I have a serious illness, and they are referring to something different. But clinically, serious illness is defined as a condition that has a high risk of mortality, so a high risk of death, and either negatively impacts a person's quality of life or excessively strains their caregiver. That's an important distinction to make because sometimes people will have a serious illness, but their quality of life could be good, but that could be because they have a loved one who's dedicated, their whole life to caring for them. So whether it's impacting the patient's quality of life or excessively straining their caregivers, and if it has a high risk of death, that is a serious illness. So this includes things like cancer at any stage, congestive heart failure, COPD, chronic kidney disease, Parkinson's, Alzheimer's. Those are some examples of serious illnesses. So now I'm going to get into what is palliative care. And this is a service that many people may not be aware of. Many times people haven't heard of it, or they're confused about how palliative care differs from hospice care. So palliative care is for the whole person, and it is specialized medical care for a child or an adult living with a serious illness. So on the previous slide, I talked about some examples of serious illness and what it is. And palliative care is available at any stage of a serious illness. So whether you've just been diagnosed or whether you've been struggling with the serious illness for a long time. And basically you will have providers, a team that works with the patient and the caregiver to provide medical, social, and emotional support. So palliative care physicians and nurses are really experts in what we call symptom management. That is kind of the essence of palliative care. What are your symptoms, whether that is pain, anxiety, swelling, trouble breathing, depression? They're really going to focus on what those symptoms are and how we can manage or alleviate them. And the goal of this type of care is really just to live better, right? If you are having symptoms such as pain and it's out of control, it's not well managed, that impacts, your quality of life. So a palliative care team will work to improve that. So this type of care is provided by sometimes doctors, sometimes nurses, sometimes a whole team. And what they will do is work with your other doctors. So your primary care doctor, maybe if you have cancer, you have an oncologist or whatever specialists, the palliative care team will work with them, not only to address symptoms, but kind of to coordinate different parts of your care. Palliative care is based on the patient's need, not the patient's prognosis. So you do not need to be dying or terminal to receive palliative care. There's no sort of life expectancy requirement. You just need to have a serious illness as defined on that previous slide. So as mentioned, how palliative care helps, it really focuses on alleviating those symptoms and managing those symptoms. And that is a special kind of supplement to your care. So an example would be, if you were diagnosed with cancer, you may have oncologists, and their focus may be to kill the cancer, right? So they might be prescribing chemotherapy or radiation. That is their focus, is to get rid of the cancer. Your palliative care team, their focus would be to get rid of symptoms. So are you having pain associated with the cancer? Are you having side effects from the chemotherapy, like nausea or something? That is what the palliative care team will focus on. It's also really important to note, though, that you can have both at once. So you can be pursuing curative treatments, such as chemo or other aggressive therapies, and you can get palliative care at the same time. The palliative care team also will work with families and caregivers to have what we call goals of care discussion. So as a as a disease progresses, having conversations with the patient and the family about what they want, about what their goals are, and about how things are going with managing the symptoms. So why would someone use palliative care? As I mentioned, it treats the whole person and it promotes quality of life. Also acts as an extra layer of support in care coordination. But really the main reason is for that expertise in symptom management. Very often when people have a serious illness, as I mentioned, they might have very skilled physicians who are working to cure that illness. But the palliative care team is solely focused on making you feel better. So alleviating those symptoms, whatever they are, so that you have more good days and so that you're able to do more. So sometimes people come to palliative care because of symptoms of their condition. Other times, like I mentioned, it's side effects from treatments like chemo or maybe both. Palliative care is a separate add-on service, so it's not replacing your doctors or your specialists. And many studies do show that palliative care significantly improves the patient's quality of life and lowers their symptom burden, which, makes sense. If we can get symptoms under control, people have more good days. And as such, palliative care has been shown to reduce frequent emergency room visits and hospitalizations. So when is palliative care appropriate? As I said, the main thing that makes someone eligible is they are diagnosed with a serious illness. So cancer, Alzheimer's, COPD, congestive heart failure. Another thing that would make someone a good candidate would be that they have unmanaged symptoms. So whether that's pain or something else, you have symptoms that are not under control. And many times when symptoms are not under control, this leads to people being in the doctor's office every week or being rushed to the emergency room multiple times. Those are all signs that symptoms may not be under control. Also, changes in function. So things like weight loss, memory loss, increased falls, these could all be signs that an illness is progressing and that it's not well managed. So palliative care may be appropriate. As I said, palliative care is for any stage of a serious illness, as early as the time of diagnosis, or, whether the patient has had the disease for a while, they can still receive palliative care. So who provides this care? It will vary depending on where you go for your palliative care because different providers use different, clinicians. But there will always be a supervising palliative care physician. So this is a physician who's trained specifically in palliative care in symptom management. And they also use nurses, sometimes RNs, and sometimes what we call advanced practice nurse or nurse practitioner is usually the main sort of point person. As I said, at some providers, you may just see a nurse who's supervised by a physician. Other providers, you might have more of a team where you see a nurse and maybe a social worker, a nutritionist, an occupational therapist. It really depends on not only who you go to, who the provider is, but also on the specific needs of you as the patient. Where does palliative care take place? This also can depend on the provider. So most providers of palliative care fall into two categories. Many hospitals or health systems have a palliative care program, and that is usually outpatient. So that usually means that you would go to the hospital or clinic for visits with your palliative care nurse or your palliative care team. And then there are also providers, we're going to talk about hospice later, and there are many hospice providers who also have a palliative care program. And those palliative care programs tend to be ones that come to the patient. So instead of visiting the doctor's office, the palliative care nurse would come and see you in your home. So those are the two most common settings. There are also sometimes palliative care teams that are associated with specialty clinics, specifically cancer clinics. So many oncology providers have a lot of cancer patients that utilize palliative care, so they might have their own palliative care program on site at the clinic. In terms of how you get to palliative care, who refers you, any physician can refer you to palliative care. So that could be a primary care doctor, just a regular general practice. It could also be a specialist. So like if you're seeing a doctor for your heart or your lungs, they can write you a referral for palliative care as well. We're going to talk about this a little bit more when we get to hospice, but many providers don't always have these conversations with patients. They don't always recommend palliative care, even if the patient might be a good candidate. There's a variety of reasons for that, but we do encourage people to be informed on palliative care. And if you think you have a serious illness diagnosis, to talk to your doctor about it. But then also later on in the presentation, I'm going to share some links for how you can find providers. So you can also call a provider and say, I'm interested in palliative care, and my doctor hasn't referred me, what are my options? And they might work with you to see if there's a different physician who might refer you. In terms of payment, which is always important, we always want to know who will be paying for this care. Is it covered? So palliative care coverage varies, and more insurers are covering it in some way every year. So palliative care is covered by Medicare, but it's part of Part B, Medicare Part B. And so Medicare Part B, palliative care is covered as what we call a fee for service. So this means that there isn't like a palliative care benefit, but rather different palliative care services are billed and covered under Medicare. What this also means is while it is covered, there may sometimes be copays associated with it. Medicaid coverage is similar. In Illinois, palliative care is covered under Medicaid, but it is not covered robustly. And what I mean by that is it might vary. So if you are seeing a palliative care team and you're getting nurse visits, maybe you're also seeing a social worker and a chaplain, the nurse visits will definitely be covered, but the social worker visits might only be partially covered or might have a copay associated with them. Many private insurers also cover palliative care to some degree, and veterans who get benefits from the VA are also eligible for palliative care. In terms of how long a patient can receive this type of care, there are no time limits on how long someone can receive palliative care service. So it really varies on the person's needs. It is very common that someone will start receiving palliative care, and that nurse or physician or whoever's on the team works really hard to get those symptoms under control. And once they do that, the patient's quality of life improves and they may no longer need palliative care. For other people and the nature of their disease, it might be a longer, more ongoing process. Oftentimes we get one symptom under control and then something else comes up. So it's really dependent on each situation, but there is no time limit on how long you are eligible. It really depends. Some people will utilize palliative care and then maybe their serious illness progresses and eventually they transition to hospice care. That's also fairly common. So we're going to be talking about hospice care shortly here. And there we go. So what is hospice care? So now we're going to transition and we're going to talk about hospice, which can be similar to palliative care in many ways, but there are some key differences, especially when it comes to eligibility and who's a candidate for hospice care. So hospice care is specialized medical care for a serious illness when a curative treatment is no longer achievable or desired. So that is one of the key distinctions. I just got done telling you how palliative care can be done at any stage of a serious illness. Hospice care, however, is really for people who are in the final stage of a serious illness. So people who are in that terminal stage. The other key difference is that palliative care, as we just discussed, can be done alongside curative treatments such as chemotherapy. Hospice care, for the most part, is when those curative treatments have either failed or the patient has decided that they no longer want curative treatments. So with hospice, it's more of a choice. Do I want to pursue comfort care with hospice, or do I want to still pursue cures such as chemo? Just like palliative care, though, with hospice, the focus is on comfort and quality of life. So a hospice team, and we're going to talk about who's on that team because it involves many different clinicians. But a team really works to enable the patient to be comfortable, free of pain, and to make the most of each day, to really live each day as fully as possible. And because of this, hospice is considered to be the model for quality, compassionate, and holistic end-of-life care. It's really a specialized approach, and it's focused on patients who have been determined to have a life expectancy of 6 months or less. So we're going to talk a little bit more about that on future slides, because that's not a hard and fast rule, but that's the main thing that makes someone eligible, is that they're in that final stage of a serious or terminal illness. So as I said, hospice care involves a team-oriented approach for symptom management, specifically pain, but really all symptoms, and also emotional support. So when someone is at the end of their life, when they're dying, it's not only the physical things that we're worried about, but all the emotions that can go along with that. Similarly, spiritual support. When people are at this phase of a serious illness, they may often be asking kind of those big questions, or they may be seeking a connection to their religion or to a higher power. So spiritual support is also a big part of hospice care. Hospice care is also very customizable. It's really tailored to what the patient wants and needs. But another really important part of hospice is it's not just there to support the patient. It's also there to support the patient's family, the loved ones, the caregivers. Because as we know, when someone has a terminal illness, that can be hard on them as the patient, but it can also be hard and emotionally draining for the people that love them. It's also really important to note that the hospice care team works with the patient and the family, but the hospice team does not replace the family, and the hospice team is usually not there 24/7. So they're really working with loved ones and primary caregivers. So this slide here shows you a typical, what we call the interdisciplinary care team, a typical hospice care team. And you can see that part of the hospice model is we consider the patient, their family, and their caregivers to be at the center of this team. And what that means is that this care team will really work to set goals, and those goals are really based on what the patient wants. We'll talk a little bit more about how that can vary. Sometimes a goal could be as simple as, I want to not be in pain, right? I want to get my pain under control. Other times a goal might have to do with doing something, like I want to be able to have a Zoom call with my brother who's in another state, or I want to live long enough to attend my granddaughter's graduation. So goals can be, medical in nature. They can have to do with the family, or really anything. So as I said, the patient, their family, and their caregivers are part of the team. Then you also have the medical director, hospice physician. You have RNs, registered nurses, and also CNAs, certified nursing assistants. You will always have a social worker, a chaplain. All hospices are required to also have volunteers on staff, so you might utilize a volunteer. Another big part of hospice is grief support. So when someone is in the final stage of a serious illness, that means that most likely they're going to die. And when they do die, their family is going to need support as they grieve. So part of hospice is access to grief support after a death. So that could be one-on-one bereavement counseling, that could be support groups, that could be people from the hospice just calling and checking in on the family, but that is also part of it. And then depending on the patient's needs, this team can also include other sorts of specialists, whether that's, a massage therapist or a music therapist or whatever the patient needs. So what are the benefits of hospice care? There are many. They have done studies where they look at two patients who have the same disease, one on hospice care and one not. And the hospice patients tend to live on average about 28 days longer, despite the fact that they're not receiving curative treatments like chemotherapy. So this is important. 28 days doesn't sound that long, but when you have a terminal illness, that's a big deal, right? That's nearly a month more time with your family, a month more time to get your affairs in order. And so really this expert care that is delivered by the hospice care team, even though it's not curative in nature, it still leads to people living a little bit longer, but also living better. So having more meaningful moments, more pain-free moments. So there's physical benefits, there's benefits for their spirit and their emotions. The hospice care team can help with all sorts of things. So on a day-to-day basis, what hospice care can look like is, logistically, it's a lot easier. People can receive all their care in their homes. They can get medications sent to their home, equipment, oxygen sent to their home. They can get assistance with bathing, toileting, administering pain medications, but also counseling the patient and their family, talking to them, being there for them, helping them figure out what they need to plan for in terms of like a funeral or grief support. So hospice really has many different benefits depending on the situation. So as I said, hospice treats the whole person, mind, body, and spirit. The team works to manage symptoms, whatever those symptoms are. People often think of pain, and yes, that is a big part of hospice is managing pain, but also emotional symptoms and other physical symptoms that come up depending on the disease. As I mentioned, hospice care also includes equipment, supplies, and medications sent to the patient's home. Provides assistance with personal care. Things like bed baths can be really helpful when someone is immobile, to have a CNA that can come and give them a sponge bath right there in their bed, rather than their caregiver, trying to help them to the tub. As I said, it includes spiritual support, usually through the chaplains, and also social support from the social worker and the volunteers. And bereavement counseling after the patient's death is a part of hospice care as well. So, when is it time for hospice care? Obviously, the answer is going to vary depending on each person's wishes, but typically it's when the goals of care shift. So when the goal is no longer cure, when the goal is no longer beating a disease or extending your life at any cost, when that shifts and you're more concerned with comfort and quality of life, that is usually when it's time for hospice care. As I mentioned, the main thing that makes someone eligible for hospice care is two doctors agreeing that a patient most likely has 6 months or less left to live. Now, I always caution people about this because we as human beings, we don't come with expiration dates, right? And this is an estimation. So just because a doctor says, yes, you have this stage of cancer, it's likely that you only have 6 months left. Just because they say that, it doesn't mean that you are going to persist for 6 more months, right? You could pass away in 2 weeks, or you could carry on for a year or even 2 years. So this prognosis is an estimation. If you are deemed eligible for hospice, you do not get kicked off of hospice care if you survive longer than 6 months. That's not the way that it works. So I always caution people, because sometimes people see that prognosis of 6 months and it prompts people to really wait. Many people wait too long before they start thinking about hospice. And then sadly, they might come on service and they don't really have a chance to benefit from hospice if they're only on service for, 3 days or a week, and then they pass away. So don't be too fixated on that 6 months, even though it is what makes someone eligible. In terms of where hospice care happens, about 90% of hospice care takes place in the patient's home. So the care team will come to wherever the patient calls home. So that might be inside, a private residence, like a house or apartment. If the patient resides in like a senior living community, the care team will go there. If the patient is already living in a nursing home or assisted living, the care team can also visit them there. So that's where the majority of hospice care takes place. There are some inpatient hospice care, and we're going to talk about that a little bit, but the majority of hospice care is happening in the patient's home. And that's actually a big part of sort of the hospice philosophy, is that people are more comfortable in their own homes rather than being taken to a place or an institution. In terms of how to receive hospice care, like I said, many people never receive hospice care, or they receive it very late in the game. So I do encourage you to talk to your doctor if you have a situation where you think hospice care could be appropriate. Sometimes, as I mentioned, people start with palliative care, and then if curative treatments fail, or if they're tired of curative treatments, they don't want to do them anymore, then they can kind of smoothly transition to hospice care. Other people might be referred directly by their doctor or a hospital. Many times people are hospitalized and they get a new diagnosis right there in the hospital. And the hospital, nurses or social worker will say, we recommend hospice care. Here's a list of some providers. But also many times the request comes from a family member. This was true in my case. I was the one who suggested to my father, I said, I think you might be a good candidate for hospice care. And because I said that, he then went to his doctor and asked his doctor about it. And the doctor said, oh, yes, absolutely, you would be a great candidate. But if I hadn't brought it up, that doctor never brought it up on his own. And part of the reason for that is there is a stigma attached to hospice care. Many doctors may have good intentions, but they may be fearful Like if I bring up hospice care to a patient, how are they going to react? Are they going to be upset? So that can be a tough conversation. Also, we have to keep in mind that doctors are trained throughout medical school. They have a real focus on extending life, right? That's all kind of what being a doctor is all about. Curing diseases, extending life. That's always their focus. Like, what's the next treatment? What can we do? And so many doctors, sometimes they view hospice as an afterthought. Hospice does not mean giving up, right? It just means that you are having a shift in what matters to you. Maybe your comfort matters to you more than having aggressive treatments. And sometimes it's hard for some doctors to kind of get on board with that. But it is very common when people have positive experiences with hospice care, that they'll share that kind of through word of mouth. You know, if you've ever had a relative use hospice care and it was beneficial, you're more likely to, you know, suggest it to a friend, a coworker, a neighbor, and that prompts them to, you know, talk to their doctor. In terms of payment, hospice care is actually covered very, very well, very robustly. It's covered much better than palliative care is. So there is a hospice benefit that's part of Medicare, and that's under Medicare Part A. So that means that all hospice care services are covered with no copays and no deductible if you have Medicare. In Illinois, Medicaid offers similar coverage. For the most part, people who have Medicaid do not pay anything for hospice care. It's all covered. With private insurances, it will vary, but most private insurers have a hospice benefit. Also here in Illinois, we have the Healthy Illinois program, which is for undocumented people who would qualify for Medicaid, if not for their immigration status. And hospice care is also covered under that program. So I always just like to provide a little bit more context. If you do have Medicare, Medicare will pay the hospice provider directly for all your care. There is no deductible, there is no copay. The only thing that you will pay is your typical Medicare monthly premium that you've already paid. In terms of how long someone can receive hospice care, again, there's no time limit. The hospice benefit never expires. Basically, when patients come on service, they're continually evaluated every 60 to 90 days. So that means every 60 to 90 days, the care team looks at the patient and says, you know, are they still in the final stage of a terminal illness? Do they still have a prognosis of 6 months or less left to live? Do they still have unmanaged symptoms? And usually the answer is yes, and the patient remains on service. There are some instances where people will leave hospice. Sometimes, it doesn't happen a lot, but sometimes people come on service with hospice care and the hospice team does a really good job getting their symptoms under control. And so sometimes they don't need hospice care anymore. This can happen specifically with people who qualify for hospice because they have Alzheimer's. You know, Alzheimer's is considered a serious illness. It can kill someone, but it can be hard to gauge. You know, sometimes someone is given a life expectancy of 6 months. They come on hospice care and they really improve, and maybe they can continue on without hospice care for years and years. Other times people will voluntarily leave hospice. This often happens because maybe someone thinks, okay, I'm done with curative treatments. I've tried everything to cure my disease. So now I'm going to focus on comfort. I'm going to go on hospice care. But then maybe something changes. You know, maybe they find out about some new experimental drug or some new surgery, some new treatment that could cure them. Hospice care is usually not done with curative treatments. So if they want to pursue that, they would have to leave hospice. But they're always welcome to come back. There is no sort of time limit or waiting period. So many people typically think of hospice as like only for people who are literally on their deathbed, only for people who have weeks or days to live. This isn't the case. My father, who had COPD and congestive heart failure, he was on hospice care for almost 2 years. And the reason for that is, he continued to have that prognosis. The doctors looked at him and said, yes, it's likely that you will die within 6 months. But because of the nature of the disease, he just kind of kept hanging on. It's impossible to tell. Some people go quicker than others. So because of that, he still had symptoms, he still had issues, and he remained eligible and kept getting hospice care. So it really does vary depending on the person. I also just want to talk briefly about levels of hospice care. As I mentioned, 90% of hospice care is happening in the home, and it's what we call routine home care. So this means the care team is visiting the patient in their home, and it is not 24/7. So it might be a nurse visiting once a week, a nurse's assistant visiting 3 times a week, maybe a chaplain or a social worker visiting, but it's not 24/7. Another level of care is what we call general inpatient care. So sometimes, despite our best efforts, we cannot manage a patient's symptoms in their home. So we might need to bring them in for what we call inpatient care. Sometimes this happens in a hospital. There will be like an inpatient hospice unit within the hospital. And then some hospice providers also have their own standalone hospice units that are not attached to any hospital. Whenever people are admitted for inpatient, the goal is always to make that temporary. So maybe they're admitted for a few days, we're able to get things under control, and then they return home. Because as I mentioned, being at home is very important for most people's comfort. There is a level of care which is called continuous home care, and this is 24/7. As I said, this is not the typical scenario, but sometimes when someone is having distressing symptoms or when they are actively dying, they need extra support. So at that point, they would be eligible for 24/7 care in their home, but that is not meant to be permanent. It's usually only temporary. And then the final level is what we call respite care. So respite care is also inpatient. It means the patient is admitted. But for respite, they're not admitted because they have to be admitted. They're admitted to give their caregiver a break. So as we said, routine hospice care in the home is not 24/7. So that means that people are still relying on family members or on paid caregivers to cover the rest of their care needs. And sometimes those caregivers need a break. Maybe a wife is caring for a husband and the wife is sick, or the wife needs to go out of town. So that patient can be admitted inpatient for respite care. Medicare covers 5 days of respite care. You can get additional respite care, but co-pays may apply. So to kind of sum up and compare and contrast, palliative care is symptom management for people at any stage of a serious illness. And palliative care can be done alongside curative treatments. Hospice care is for people in the final terminal stage of a serious illness, and it is usually done without curative treatments. There are no life expectancy requirements for palliative care. You just need to have a serious illness. For hospice, the main requirement is a life expectancy of 6 months or less. Palliative care is covered by Medicare Part B. Co-pays may apply. Hospice care is covered by Medicare Part A, no copays. Palliative care may be delivered by a team, a nurse, or a physician who works with your other doctors. With hospice, you have a full interdisciplinary care team that will visit you in your home, and hospice also includes bereavement support for up to 13 months following the patient's death. So as you can see, there are some key differences, but there's also a lot of similarities, right? Both palliative care and hospice care focus on managing symptoms to make people feel better. We can get pain symptoms, if we can get emotional symptoms, breathing symptoms under control, people feel better, they're able to do more, and they have a higher quality of life. Both types of care can also include ongoing emotional support. So understanding that serious illness is not just physical, and there are emotional and psychosocial components of that. Both types of care will include coordinated communication. So making sure that the healthcare team, the patient, and their loved ones are all on the same page, and ongoing discussion of goals of care. So if a patient is on palliative care, it's really important that we talk about what are our goals. And the same goes for hospice care, whether the goal is a big thing or a relatively small thing, that's kind of what the team will work towards, is helping patients to meet those goals. So in conclusion, I hope that today you learned a little bit about the differences between palliative care and hospice care, the benefits, and how to access these types of care. Palliative care can help with symptom management while still allowing for curative treatments, and hospice care is a unique approach to improving quality of life for people who are dying or are facing a terminal illness and their loved ones. And I like to always end with this quote, which is that the end of life deserves as much beauty, care, and respect as the beginning. I will share these slides. This is the link to our website. We have some guides that can be helpful if you are interested in looking at hospice or palliative care providers. It includes some questions to ask, and it also links to some Medicare data that kind of ranks providers based on surveys that other patients have filled out. Just a reminder, my contact information and all the education that is offered through the HAP Foundation. There's my contact information again. I'll put it in the chat too. And finally, ask you to take a moment to complete the anonymous survey. I put the link in the chat. I'll put it in again. You can also take out your cell phone and point the camera at the QR code there, and it will take you directly to the survey link. It's a very quick survey. You don't have to give your name, but my position is funded through a grant, so it really helps if we can collect survey data to kind of show what education we're doing in the community. So I'll also put that link in the chat. And with that, I will stop and say thank you so much and open it up to see if we have any questions or comments or anything that anyone wants to share.
Everyone can unmute themselves if you have a
I see
question
hand
or
up.
comment.
Kathleen?
Hi there. Thank you so much for this really useful information. I appreciate your time and your planning and organizing it all. I have a question about Medicare Part B coverage for palliative care. Correct me if I'm wrong. I just want to state how I understand it. And if I make a mistake, let me know, okay? My understanding is that palliative care would be covered like any other medically necessary service under Medicare Part B, and that there is really never a requirement that an illness be life-threatening for Medicare Part B coverage.
Well, I would say this. That sounds correct to me. I'm not a Medicare expert. So for Medicare, there may not be a requirement that it's life-threatening. As I said, to be eligible for palliative care, you must have a serious illness, but it can be at any stage. So my understanding is anyone who has a serious illness, and we talked about what that means, if you have a serious illness diagnosis and you have Medicare, then it should be covered under Medicare Part B. There may be copays associated with that care. Part of the problem is ideally we would like palliative care to have its own Medicare benefit, the way hospice care does. And right now it doesn't. So that means that it's covered, but depending on the service you access, you might have a different copay. So if you see a palliative care nurse, that might be fully covered with no copay. But if, you know, you see a social worker, that might have a copay. It kind of depends on the specific palliative care service. So I don't know if that answered your question.
It's helpful. I think it's important to realize that Medicare covers palliative care under both Part A and Part B. Tests are different. For Part A coverage, that's where you have to meet the qualifications, I believe, for hospice care, and do have to have a life-threatening illness. But under Part B, I think, again, it's just like any other care, as you say, which is going to vary a lot depending on what the type of care you're getting. But if it's deemed medically necessary, it's going to fit into Medicare's regular qualifications for reimbursement. And it can be a serious illness that to meet any, that test, that definition you gave at the very beginning included life-threatening in it. And I just kind of want to underscore that I don't think that Medicare Part B type palliative care requires life-threatening. I think it's just medically necessary like any other medical care. And then again, as you say, how good that's going to be depends on how Medicare covers the service, the specific service you're getting. It's going to be much better for MDs, for example, than probably for mental health care, although I guess that's improved in recent years. Anyway, I do appreciate
so it's a great question. And I will say this, palliative care is continually changing. And part of our work at the HAP Foundation is to expand who can be helped by palliative care. But I do just want to make the distinction that you cannot get palliative care for any illness. You know, so sometimes people come to us and they are suffering from chronic pain after surgery. They usually do not qualify for palliative care because that's not a serious illness. It's not an illness that has a likelihood of causing mortality. So I just want to make that distinction, but you're probably right in terms of the Medicare. That's why palliative is under Medicare B, whereas hospice is under Medicare A.
Yeah, the providers have one way of qualifying people for their programs is what I hear you saying, whereas Medicare reimbursement is another issue. A palliative care program isn't looking to help someone with chronic pain that isn't life-threatening. But that may be palliative, and Medicare Part B, well, if it's medically necessary. So it's like two different worlds almost, what the providers are, how the providers are organizing their delivery of service versus what Medicare Part B will and will not pay for. It gets a little complicated, but it's just good news to know you don't have to have something life-threatening to get what constitutes palliative care. You just may not be able to get it from a palliative care organization. Which
they
you're
might
clarifying
not deem
for
you
me.
eligible.
They might not want to include you in their priorities. That's helpful. Thank you.
You're welcome. And Irene did put some contacts for specific Medicare questions in the chat. I'll also say that, you know, this is an ongoing issue. Those of us who work in palliative care, we are seeking to expand it. So like really in my ideal world, we want palliative care to start earlier, right? So right now it's limited to a serious illness. I would like to see it expanded to chronic illness. And I'm not alone in that. Many people would like that. but that has not, happened at this point, but it's possible in the future. So these are great questions.
Can you
Anyone
share the,
else?
can you share the chat with us before it disappears?
I'm sorry?
You put a lot of info in the chat. Is there a way for us to get that and save it?
Yes, if you open up the chat at the bottom, there's 3 dots next to a little smiley face. And if you click those 3 dots for more, it'll come up save chat and you can save what's in the chat.
Thank you.
Sure thing. I'm also going to pull up the survey link one more time and put it in the chat. But if anyone else has a question or a comment, feel free to speak up.
I will also share the link to the survey as well as the slides once Maureen shares them with me. So I'll be providing the slides and the recording to everyone that's registered.
Yes, thank you so much, Irene. I think it'll be helpful too, because on those slides, like I said, there are some links to the HAP Foundation. So if you do have a situation where you or someone you love might need this type of care, you can check out, we have guides in terms of like what questions to ask a provider. And also we have on our website, more details about who's eligible, when palliative or hospice care is appropriate. So definitely check that out.
Okay, are there any further questions? Okay, well, we want to thank Maureen for tonight's presentation. And I also want to remind everyone, next week will be our 3rd session, but it will be in person at the Evanston Public Library on the 3rd floor. And it's titled Coping with Grief and Loss. So that's March 20th from 6 to 7 in the Falcon Room at the main branch. Hope to see you there.
Yes, thank you. Thanks for having me, and everyone have a wonderful evening.
Thank you, everyone.